All right, thanks everyone. I just got off a flight from Vancouver, so my battery's about to run out, so I'm not going to talk for the full half hour. So I'm just going to give a quick overview and also throw out some discussion points to the audience. So I'm just going to go through a couple of the themes that were talked about in this morning's session. So we heard from Mark Atkinson, some beautiful imaging techniques to understand encephalitis, and that's just like a screenshot from the looking at the varying CD8 positive T cell infiltrates in the islets of Langerhans, and also demonstrating that what we've been seeing immunohistochemically is very similar to what we can see with more high quality imaging techniques now, and also showing the capability of CyTOF as well as the IMC techniques, so we can have multi-parameter staining for greater accuracy. And he also just demonstrated the heat maps that you can generate from much of this data, looking over time in terms of what happens to islets and how they change with the duration of diabetes. So obviously he also talked about it's not just being the endocrine pancreas that's at fault, and this is I think something I found very interesting as part of the islet transplant program. We have an issue with pancreas donor organ availability, and we have rather strict cutoffs in terms of age and BMI, but obviously there's a very wide distribution of available beta cell mass that we can't actually predict with any of the clinical characteristics that we're given over the phone by the donor coordinators in the middle of the night. And the nature of the funding of the islet transplant program is that we just can't isolate every single time because of a cost issue, and that really limits the number of transplants we can do and the number of isolations that we can do, with the knowledge that only 30 to 40% are probably going to reach clinical grade criteria to allow for transplantation. And so Mark Atkinson also showed data with regard to size of whole pancreas, depending on whether you were diabetic or not. Oops, sorry, how to go back. And also showing pancreatic enzyme changes in relation to type 1 diabetes status and autoantibodies. So I showed this previously. The isolation procedure that is characteristics of the islet isolation labs around the world is it's not great for the islets. Once they're stripped of their vascular network and their extracellular matrix, they really hate it. And once you put them through that purification process, they've got limited longevity. And so Peter Thorne obviously showed this significant difference in terms of intact matrix structure, which is necessary. And once you're infusing islets into the hepatic portal system, they need to reconstruct all of this angiogenic network and their matrix. And in that intervening engraftment period, they're completely dependent upon passive diffusion of nutrients and oxygen. And these islets are very large, and obviously they're very metabolically active. So this is part of the problem, and you get a significant attrition rate at the time of transplantation. And so we need to somehow optimise angiogenesis and matrix deposition to facilitate the islets working. And so Peter Thorne also showed this. So, isolated islets don't work the same as they do in vivo when they're surrounded and communicating appropriately with their endothelial cell network. So, obviously, islets within the endocrine pancreas are not the same as isolated islets, and they're not the same as stem cell-derived islets. And nice emoji sequence there that I think accurately reflects what we have. And so Jackie Scheisser showed some really lovely data in terms of how we can use stem cell therapy to our advantage, either in terms of replacement of beta cell mass versus modelling of the disease process. And so these really pretty pictures with lineage tracing to demonstrate that you can drive cells in this fashion so that they're differentiated appropriately, but not 100% of the cells are differentiated, and also showing that you can use this methodology to study cellular interactions in type 1. So Anand presented some work looking at modifiable versus non-modifiable risk factors, and so this is a composite of many of the studies that have been undertaken, and the debate over the chicken and egg phenomenon over autoantibodies versus are you dysglycemic first, and this publication demonstrating the relationship between those two variables as being interesting. So Anand's group has also looked at the importance of microRNAs, and he didn't present this work, but I'll just direct you to their recent publication looking at a whole host of microRNA transcripts and how they relate to insulin transcripts, and showing a clinical correlation there on the right-hand side. And this diagram is taken from that paper, looking at changes in up and down regulated microRNAs based on whether you're a progenitor cell, and then if you differentiate into a different type of endocrine cell. I think that's instructive, in addition to Sam Alostra's talk about epigenetic modification. Which was that particular slide. Okay, so Shane, you didn't upload your talk, so I had to take some screenshots. So that's why they're looking secondhand. So getting back to when we isolate islets, they don't behave normally, and they're super inflamed, and that's part of the problem, probably why they don't do particularly well at the time of the peri-transplant period. And so Shane showed this lovely sequence of events related to single nucleotide polymorphisms related to the A20 gene that change your immunity based on NF-kappa B, toggling of NF-kappa B activity. And then obviously if you have a pro-inflammatory expression, your islets are significantly worse off. Okay, so what was I going to say? Apropos of the discussion that happened before, the Westmead has a national transplant program both for the islets and for the solid organ pancreas program. And I recently gave a talk interstate. We're actually heckled by a number of endocrinologists who don't inherently believe in islet transplantation. I know Jane alluded to that. And so this this study is a few years old now, but this was a clinical service where they had specialist endocrinologists and islet transplantation, and so they were able to resolve problematic hypoglycemia with optimal medical therapy, and about a quarter of those were able to achieve a clinically relevant improvement. But we still had a quarter of patients requiring islet transplantation, and I was just wondering from the endocrinologist in the room whether you consider the advent of newer insulin pump techniques to abrogate really the need for islet transplantation. I just wondered if there was any comment from the room.
Yes, being an adult endocrinologist,
Yeah.
Before, it will limit the number, but there are certainly people out there. I certainly had one patient who actually used to work for us, who went out to Westmead. She hasn't made problems. To this day, obviously the connection hasn't occurred there for her to get a transplant. I don't think it's just the referrals, it's also basically the basis of which decision is made.
I mean, yes, at the moment, because you have to have severe hypoglycemia and hypo-unawareness, the inclusion criteria are very strict, and so not all potentially suitable type 1 diabetics are going to make it past the referral process. But certainly I do wonder whether newer technologies are going to reduce the number of appropriate referrals.
Hi, Sybil Macaulay, adult endocrinologist in Melbourne. I also work at St Vincent's where we have the islet transplant program, and certainly over the last decade very exciting to have had the first successful islet transplant happen at the end of 2007, and then the islet transplant program going from the research world into the clinical realm, so we now have it there. At the same time, and we'll touch on this afternoon, we've had a big decade with technology. And so I think working in the type 1 service there are a whole lot of people who potentially previously would have gone down the path for referral for islet cell transplantation, but we do now have a lot of other options. So I think technology's come a long way. It's absolutely the Band-Aid while we wait for prevention and cure. But I think when the competitor is deceased donor islets and it's full immunosuppression, that's a big competitor. And so I think technology has had a lot to offer, and look forward to sharing some about that this afternoon.
Yeah, no, that's a great point in terms of immunosuppression. Do you want to pass the microphone to...
So if I can make a comment which might be a bit controversial. So in our area in Cardiff, we've almost stopped doing PTAs, pancreas transplant alone. And the reason is that the outcomes were poor.
Yes.
We do a lot of SPKs, simultaneous pancreas kidney. We've almost stopped doing PTAs. Now, one of the reasons probably behind this, I'm trying to phrase this in as tactful way as possible.
Oh, that's right, I'm a pancreas transplanter, it's okay.
Well, is that, no, it's not to do with the transplanters, it's to do with the people. So the people who most need a pancreas transplant often, as in one to take their disease away altogether, really struggle with their disease in the first place, have a trouble engaging with some of these medical issues, and they were generally poor at taking immunosuppression reliably. We had a fantastic patient presentation earlier on. He's obviously amazing at doing this. But quite a few people had an issue about regular taking of these drugs and all sorts of things like that, and they pushed back and they lost their transplants. So I think there's an issue here about the people who most need it are the people we least want to give it to. And this is what used to happen at the beginning with pumps. When I started doing the pump clinic, we could only give it to people who would do finger sticks like 20 times a day. And those were the people who didn't need a pump. They were doing very well themselves. So I'm not sure if I'm expressing this very well, but actually the need is for people who can do a plug and play and deal with people who have trouble interacting with their disease.
I mean, that's true. We have an SPK, a robust SPK program, and very few people would be eligible for a pancreas transplant alone, but we won't offer that for type 1 diabetics with normal kidney function. We'll do a pancreas after kidney for those who had failure from their SPK, their initial SPK. But you're right, and I think part of the problem is perhaps the way we're selling it. It's a treatment and not a cure, and the emphasis on the immunosuppression, I think, is probably not sufficiently recognised by the medical profession and not appropriately communicated to the patients, because it's a burden, and they're not without the significant side effect profile that I was going to touch on here. Well, this is just a slide to look at how far we've come. Even though really islets were probably the last primary cell to be successfully isolated by Paul Lacey. I don't know how these guys in 1893 managed to smush up some sheep pancreas and implant it into the omentum of a 15-year-old kid with diabetes. There was obviously no clinical governance then, but they did that, and the boy died, obviously. And then Paul Lacey isolating islets, and then in Pittsburgh, the first successful series, but limited insulin independence, and of course the seminal study of prednisolone-free immunosuppression in 2000. So this was some data that was actually presented by James Shapiro at the TTS conference in 2020. I have not seen that in a publication, but what they had done is gone back and look at 20-year cumulative survival, and so depending upon the time where you were diagnosed with diabetes and whether you had a positive albumin creatinine ratio or not, and then they had an age-matched cohort of type 1 diabetics receiving an islet transplant, and they looked at cumulative survival, which was inordinately better, so that's despite immunosuppression, which I thought was interesting. Toby mentioned before about SPK transplantation. So Westmead Hospital's done, I think now 640 kidney pancreas transplants over the 30-plus year program. Just looking at our survival, it's pretty good early on, but our 20-year survival is poor. And we've made significant improvements over subsequent 5-year intervals, and this is from Anne's data. So our 5-year survival rate's pretty good, but still not 100%. So we know that a solid organ pancreas transplant can restore euglycemia, decrease short and long-term mortality, and provides durable freedom from insulin. It obviously impacts upon the incidence of diabetic nephropathy. It can stabilise retinopathy, stabilise peripheral neuropathy. There's less evidence that it clearly reverses established macrovascular disease. I'll probably just skip over this, really just showing that peripheral vascular complications are reduced. We don't have the same level of data clarity for the islets in terms of their complication rate. And it's half-life. Okay, so I alluded to calcineurin inhibitors, so tacrolimus that we use routinely being bad, and I showed you that particular graph where the incidence of renal impairment increases with time following exposure to CNIs. This is actually from the Transplant Consortium's 2013 publication, really looking at stability of renal function over 5 years, and there's fluctuations in serum creatinine. We all know that's a bad biomarker of renal function anyway. So just to touch on long-term complications related to immunosuppression, the issue of cardiovascular disease, which will kill the majority of immunosuppressed population anyway. There's also the issue of malignancy. This is in solid organs. And so you see that over 25 years worth of immunosuppression, you've got significant incidence of skin cancers. And this is the kind of graph that you look at, that looks at all cancers versus skin, solid organ and hematologic cancers, which are a significant burden for our population. Toby talked about CAR-Tregs targeting GAD65 and you know, the new types of cell therapy that can be adjuvants to our current immunosuppression. Oh, no, sorry, that's it. I don't know if anybody has any other comments that they want to add. I'll leave it at that.